I think we're going to slightly change the order of presentation, if that's okay, Richard. So Catherine will nicely follow on Mark's presentation in terms of what's going to happen or what's happening in the Midlands and the plans going forward. Thanks, Catherine. Catherine is a K-Quick program manager who's been in the Midlands for several years now as the regional program manager, and has been heavily involved in the various work that K-Quick has been doing in the Midlands, and more recently around home dialysis and DAYLife. Thank you, Catherine.
Thanks, Uday. So I'm very much presenting this on behalf of the Midlands Kidney Network as a team. So I'm here with Marie Atkins, the network manager, and Mark Lambie, who you've just heard from. So I'm going to talk about what the state of play is in the Midlands Kidney Network for the around home dialysis, and what we're planning to get to the 20% GIRF target. So there is a bit of an overlap from what Mark just shared. So forgive me about that. So, sorry about that. Actually, the Midlands have been involved in DAYLife since 2019, so before COVID, a long time ago, when Richard Fluck actually devised the programme, and it was the region's K-Quick priority project. And then COVID put a bit of a spanner in the works for that regional project. But as you can see, the Midlands has lots of units in the Midlands are actually exemplars, and the region has the highest prevalence of home dialysis in the country. So this is quarterly data from regional networks on the prevalence of home therapies for each region. So this is a national picture at a regional level. It's missing a few networks from the picture, and one of them can see just up to 2023. And this is something that's been set up as a kind of interim dashboard. Hopefully in the next few years, all of the units will send live data feeds through to the registry, and we'll be able to have this national picture on a quarterly basis using the renal registry portal. But in the meantime, this is something that networks have set up. And so you can see the GIRF target, which is the dotted line, and the average prevalence across these regions. So the Midlands is good compared with other regions and nationally, but actually in terms of home therapy prevalence, there is still a large variation. And I think almost half of the units, if you look at a unit level, are falling below the 20% target that's set by GIRF, and also appears to be falling in quite a few units over the last few years. So there are two things we've been trying to do in the network. The first of which, when we originally looked at home therapies in the network, when the renal networks were set up just after COVID, peritonitis was one of the main reasons for people transferring to in-centre haemodialysis. And this data shows, this is from 2021, the end of 2021, when we were looking at setting up the project, that many units were having the infection rate above 0.4 per patient year, which is the ISPD standard, and lots of units were getting worse as well, it looked like. So we thought if we could reduce peritonitis, we could help to increase the prevalence of people staying on home dialysis, as well as improving the quality of care. So we started the project, as I said, back in autumn 2021, and this was the aim we set ourselves. In fact, I think originally the target was to the end of March 2024, and then it was 2025, and now it's 2026. But we wanted to get an average infection rate of below 0.35 and no unit to be above the 0.4 per patient year infection rate in the East and West Midlands. So K-Quick promotes the Institute for Healthcare Improvements model for improvement, and that's about supporting tests of change, which are small and non-disruptive, before rolling out successful interventions. It encourages teams to really think about what they're trying to achieve, refine their aims, and get the right people in the room before, and to really understand what system they're trying to change before going ahead with making the change. We offer training in quality improvement methodologies at a local unit level and through regional events with the network, and bring people together regularly across sites to share progress and develop that learning community. So through this approach, teams develop change ideas, and there was a lot of change ideas based around patient training and education. But one of the key themes that emerged was actually wanting to either review a root cause analysis after peritonitis that was already being used locally, or develop one if they hadn't got one already as part of this QI initiative. So most teams came up with this idea on their own. And we felt like if we could actually standardize this approach, where everybody could collect a root cause analysis with the same data items included, we could actually provide some guidance and consensus about what to look at, and then also pull that learnings, have a greater evidence base around some of the causes of infection and help to reduce, prevent infection in the first place. So that was the idea. So we tried to develop a standardized root cause analysis tool. This is how we did it. So we looked at all of the tools that existed in the region. We pulled them together centrally, listed all the items that were included and their frequency. And then we came up with a standardized version that we then shared at a regional meeting and got feedback on, discussed what items to include and exclude. And then Professor Mark Lambie came up with a list of risk factors as well that was circulated by email for comment. And then we developed the standardized root cause analysis tool, which is basically an Excel spreadsheet. It's gone through a series of iterations. So we're just looking at version 7. So it was piloted in a couple of regions, got feedback, and then it was rolled out across the Midlands, shared with other networks like London Kidney Network and some other units. And all of the feedback has been pulled into this version 7. And we look at past or present exit site infections, past peritonitis infections, details on patient training, as well as details around the patient themselves. And then in the latest iteration, there are specific questions around wet contamination, hand washing technique, home environment, and other issues. So we're working on refining this tool and looking at other networks and units as well who we've shared it with, who are implementing it locally, like Sheffield and Oxford, and getting their feedback to really hopefully support wider learning around infection prevention. So in the Midlands, we've collected 12 months of this data so far, 12 months of standardised root cause analysis data. And that's been on over 300 episodes of peritonitis. And it's taught us quite a few things, actually. The first is actually this root cause analysis process, the review, is a really practical way of promoting continuous quality improvement locally. So it allows people to constantly reflect on how this can be avoided, what can be done to prevent it in the future, how can we stop this happening again, and come together to discuss that as a multi-professional team. The other thing was around about 50% of all the episodes were missing the date of the last training or last technique review. So actually, it just highlighted the importance of having training dates and documented systematically. And we're looking at that across the region now to make sure that's something that is in the system so nobody falls through the net. Common risk factors that were identified were included gastric acid suppression usage, poor hand hygiene, a change in dexterity, mental health, or mental acuity, or vision, and wet contamination. And in some units, a focus on hand washing, we heard from Coventry earlier, focus on hand washing and retraining really helped reduce their rates. And this simple intervention could be something that is a quick win for the region, given that hand hygiene is such a common risk factor found within the RCA. So the approach is informed prevention locally as well. So this is a quote from one unit. With historically high rates, they've seen a real reduction over the last few quarters, which is really great. And they say that the RCA's value seems to be getting everyone in the team involved in looking at why their rates are high and looking at the themes and trends. And one of the things they observed was when completing the RCAs, how difficult it was to establish when patients had technique reviews and training. So like I said before, they're now documenting this in a systematic way. And they found a correlation between patients engaging in technique reviews and their risk of peritonitis. So they can use that now to help identify people who might be at risk and change their practice on the back of it. And this is another unit example from who have seen a big reduction in their peritonitis rates. And they say, again, the RCA's prompted more in-depth discussions with their microbiologist teams, looking at their treatment plans and additional medications to current medications being used. And they've documented a hand washing technique and reviewing patients' do's and don'ts regularly to get help from on a quarterly basis. And this was decided after using the RCA tool. So embedding it and importantly involving the whole team in reviewing and responding to the data has begun to help teams with their prevention efforts. So this is the average rate of peritonitis across the region and for the duration of the project up until the first quarter of this year. So you can see there's been a bit of a reduction. We're not quite where we want to be, but we've definitely seen some improvement. So that is continuing. We're continuing that project. But we've also now this year, as Mark said, we've shifted the attention to increasing uptake of home dialysis as well. So the DAYLife approach. We're focusing early on in the pathway and across the pathway, so linking with advanced kidney care, in-centre teams and the whole team. So how are we approaching DAYLife this year? We really want to understand the local context specific barriers to increasing uptake of dialysis at home. We know that not one size fits all. So how can we reflect on people's current situations and think about how things can be done better? We want to learn and share evidenced ways of overcoming these barriers. So that's really about the INTERCEPT study that Mark's just talked about. There's been really significant research. So how can we actually implement that in practice? We want to develop with QI teams and a network. So we want to provide some structure and methodology to the change. And then finally, we want teams to feel motivated and supported and equipped to implement that change. And that's really about doing it together as a network, because no change is easy, but actually if you're doing it in isolation, it's incredibly hard. So coming together on a regular basis, sharing those local challenges is really important to the project approach. Mark's already shown this, but this is what we've done this year since relaunching DAYLife really in the Midlands. What have we done? So we've recruited QI DAYLife leaders across the network to lead the change project locally. We've run 2 out of 4 of our QI virtual QI course sessions. That's for anyone taking part in the KQIP project in the Midlands, to just help them, to guide them through those quality improvement steps and help them to set up their projects. And then we ran our launch event in May, talked about that evidence around home therapy uptake, talked about how we can really sustain the changes we're trying to put in place and lay that groundwork. And then I've been carrying out local unit site visits and meetings to talk to teams about their local context, do some process mapping, refine their SMART aims, so really specific, measurable, achievable and relevant aims. And then we've got our next regional workshop on the 24th of November. So as Mark said, some interventions are tangible and measurable, but then others are, and these have been all evidenced by INTERCEPT, others are really less tangible. So things like supportive leadership, a culture of continuous improvement, culture of assumed eligibility for home therapies, these have all been shown by INTERCEPT to have a significant impact on home dialysis uptake at units. So we want to really make sure these findings are incorporated into our project and get some learning from units on the ground about how they're going about making some of these cultural changes and what that actually looks like in practice. So what's next for DAYLife? As I said, we want to capture the learning from these cultural changes, as well as the more traditional interventions. So for example, what do home therapy champions look like on the ground? How do they work in practice? Where are there examples of improvement culture and reflective practice that we can promote as a region and nationally? And we're also using patient partnerships. So our network patient leaders are working with us to capture some of those stories of where patients and teams have worked together to overcome barriers and challenges to home dialysis. And also looking at how the things like reimbursement schemes are working for from the patient perspective. And then similar to the peritonitis project, we're looking at implementing interventions, measuring their impact, using those KQIP 10 steps, the Institute for Healthcare model for improvement. So there's a real methodology to people's change. What's next for peritonitis? We want to carry on collecting and sharing that data from the standardised root cause analysis tool. We really want to collaborate with other areas as well to get a consistent data set and maybe pool our learning from that. Get feedback from other units as well in order to launch that version 7 of the tool that I talked about, and maybe potentially begin to analyse differences between units as well as the whole set. So I just came up with this on the train. Maybe we should aim for 26% in the Midlands by 2026. Nobody will be able to forget that. But yes, watch this space, and I want to thank the Midlands Kid Network and all the quality improvement teams on the ground who are actually doing the work, who are all listed along here. Thank you.
Thanks, Catherine. Any questions for Catherine? Can't see any.